Good morning, everybody. I have a special early morning recording for a very special episode. We call this our advocacy roundup because every few months we like to give listeners an update on what is going on in neonatal advocacy. I actually have on two return guests in the studio this morning, Dr. Shetal Shah and Stephanie Glier. Thank you both for joining me again.
Thanks for
Great.
having us back.
Yeah. This is what we call Incubator by sunrise because
That's
for those of you guys listening, it's 6 a.m. in the morning because it was the only time we could get everyone's schedules to work between pre-call and post-call and,
travel.
and travel. So
And you guys felt it was so important that we had to get it done. So I want to make sure that we can talk about why this is such a critical time for people to be listening and how to get engaged. If people don't know who you are, or you both are, which would be nuts, but it does happen. Dr. Shuttleshot or NICU Batman, if you follow him on social media, and if you don't, you definitely should. A practicing neonatologist and researcher, professor of pediatrics in the Division of Neonatology at New York Medical College, a member of the Westchester Medical Center Health Network, and is co-chair of the AAP section on Neonatal Perinatal Medicine Advocacy Committee and former chair of Pediatric Policy Council. Dr. Shaw's technically our advocacy correspondent and has been on the show many times. And then I have on Stephanie Glier, Senior Director of Federal Advocacy for the American Academy of Pediatrics, where she leads federal advocacy to promote children's health care coverage and access to care, as well as effective financing, quality, and delivery of care for children. Thank you both for being on today. I wanted to let people know we have had Shuttle on the show many times to get kick off our advocacy, and we had you both on episode number 250, Keeping Babies Covered, Medicaid Matters, and some of our other advocacy episodes you can search for on the website. And those episodes are 114, 121 to 124. We did a whole series, and again, number 250. We actually also reviewed Shuttle your op-ed on Neo News episode 295 regarding the Preemie Act. And actually, before we get started, I mean, I think that's all part of the situation here. I'm going to give you a brief moment to catch people up on the changes with the Preemie Act before we dive into the topic for the morning.
sure. So right now, unfortunately, the Preemie Act is kind of on the back burner.
Yeah.
This is something that Stephanie has taught me and that the American Academy of Pediatrics, I guess the DC office, and I just want to shout out to them because they've really been instrumental in not only teaching all of us about the importance of these policies, but also talking about and really being a leading voice in Washington for children. Um, Congress can't walk and chew gum at the same time. Um, that's that's literally a quote from people in the DC office. Like if it's
Not everybody's a multitasker,
if it's infrastructure week, then that's what they're talking about. If it's defense week, then that's what they're talking about. So while all of the oxygen is being sort of used to talk about the so-called big, beautiful bill, which is the terrible, no good, very bad bill that's being, that passed the House and is now in play in the Senate. Things like the Preemie Act and that funding that it would provide for neonatal research and the education that it would provide to the center, the funding that it would provide to the CDC for education on things like why uncontrolled diabetes in pregnancy is bad and why it's important to take folate. Um, all of that, unfortunately, is kind of on the back burner, and it's sort of thrown into. And Stephanie, I'd love to get your thoughts on this. Sort of a larger sort of government philosophy about what really government should pay for and what government shouldn't pay for. Um, and by that, I mean, you've seen a lot of moves to curtail funding for the NIH, which would be devastating if we cut NIH funding in half, and changes for the CDC in terms of focusing more on infectious disease and infectious disease surveillance than education for things like preterm birth um, and maternal and child health. So unfortunately, while we're still talking about it, and I'll never miss an opportunity to talk about it because it is a specific piece of research that directly impacts the care we give. right now, I think that we have unfortunately bigger fish to fry, and that could be the destabilization of the entire way children's healthcare is funded in this country. And that really in and of itself is disconcerting. And then, I mean, Dav and I were just talking about this right before we started recording, which is that if you can't see the Senate bill or the House bill that we're talking about now and draw a direct line as to how that's going to impact our work, it's going to be very apparent if this bill passes what our lives will be like in 2 years and 3 years. And I say that because we've spent a lot of time in neonatology. I know you had Satyan on, you had Scott on, Duncan on. We spend a lot of time now paying attention to how neonatologists get paid, how neonatologists generate RVUs, and how much of that money is, whether you want to call it donated or taken by children's hospitals to fund other parts of the children's hospital enterprise for subspecialists that don't bring in the revenue that we do. Um, if this passes, that entire system gets undermined.
Thanks for the overview. And Stephanie, yeah, please weigh in. I also wonder if there are people who are not so well versed in the bills as you two are. So maybe we can talk about some of the specifics and how it will impact our community specifically.
Yeah, always happy to share more about this. I hope that most of your listeners are not as familiar as I am with what is in or what is not in the One Big Beautiful Bill Act right now. This is definitely my day job. So hopefully most of you are focusing on caring for preemies and other kiddos in the NICU. So just to back up for a second, I think one of the things that Shetal said is really important here for a lot of us. Many of us haven't thought a lot about how Congress works since Schoolhouse Rock was the primary curriculum here, where we talked about being a bill and being sitting on Capitol Hill waiting for them to pass you. Most of the time right now, Congress doesn't do a single bill at a time. They do these big mega bills, omnibus bills,
But
where they
bundle
package a
bills.
whole yeah, they package a whole bunch of things together that are attached to some sort of must pass legislation, where there's some sort of existential threat that requires them to pass something, and then a whole bunch of other bills get added into that package. And this is certainly one of those examples where there is a set of priorities that the folks who are currently in leadership and in the majority have outlined. President Trump certainly driving the train on this one with his policy agenda, what he campaigned on, what he laid out as his primary agenda at the beginning of his of this presidency back in January. And that's things like renewing the 2017 tax cuts, increasing border security, doing a number of other sort of tax-focused provisions that really have nothing to do with Medicaid at all. Medicaid was not something that the president campaigned on, and the way that this has rolled out is that there are very narrow margins in the House and the Senate. The Republicans have very narrow uh, majorities in both of the chambers, and that means it's really hard for them to pass legislation. In the Senate, this is especially important because of the filibuster. So, thanks for bearing with me as we go back into our Civics 101 here. The filibuster allows a senator to hold the floor and block any other discussion from happening and block votes from being able to go forward, unless you can override a filibuster, and that requires a two-thirds majority of the Senate. That's a big majority, right? I mean, it's unlikely for anybody to have that much support on a bill, especially when we're talking about a very partisan issue like advancing one specific president's agenda. So, in order to get around that, Congress is using the budget mechanism. The budget qualifies for some special privileges in Senate procedures, and in particular, you cannot filibuster the budget in the Senate because the Senate has decided that that needs to be it's really important to be able to, allow Congress to hold the purse strings of the US, and so that needs to be able to move forward every year. In order to qualify as a budget bill, though, that means that legislation also has to be relevant to the actual federal budget, to the deficit, to federal spending, and that creates a whole bunch of, like, funny little rules that Congress has to meet in order to qualify for the special privilege. So right now we are using this mechanism, which is called budget reconciliation, where they have put together the president's agenda for tax policy, for immigration policy, border policy, and they also need to be able to pay for all of those policy priorities in order for all of this to qualify as a budget bill. That has just changed the dynamics of how both the House and the Senate are talking about this. Medicaid is really only on the table here because they are looking for ways to pay for those other priorities. Nobody here was running a campaign focused on making major changes to the Medicaid program. In fact, we're only talking about the Medicaid program because during the presidential campaign, President Trump had said he wasn't ever going to touch Medicare or Social Security. So if you're looking at federal spending, on the mandatory spending side, outside of defense, Medicare and Social Security are uh, the top 2 spenders. That's where we spend the most money. And if you take those off the table, the next biggest pot of money going out the door from the federal government is on Medicaid. And so we are talking about Medicaid right now because it is seen in a lot of cases as sort of a big piggy bank where we could use money out of the Medicaid program to reduce federal spending on Medicaid to pay for these other priorities.
That's very helpful. Thank you. And so what do they want to do with Medicaid? What would happen if this bill passes?
Yeah, there are a whole bunch of things built into the Medicaid title right now that the House has passed. And I do actually want to answer this question, but I want to do one more like level set of where we are.
Please.
So, over this year, we've had a lot of debates. Right now, the House has passed an entire budget reconciliation package. So the full House has voted on it. They've approved a specific set of policies. Right now, the Senate is considering that exact legislation and talking about whether they need to make tweaks to that legislation or major changes to that legislation in order for the Senate to be able to pass it. After the Senate takes action, if they have made any changes at all, which is very, very likely, then it will have to go back to the House and the House will reconsider the version that the Senate has passed. Um, that means that we are not done. The Senate is trying to be done by July 4th, so the next few weeks are going to be really critical in making sure that members of Congress, senators in particular, understand how impactful and how far-reaching the policies are that they are considering. Once the House and the Senate both agree and are both able to pass the same bill, then the president can sign it into law and it will become real. But we're not quite done yet. So what is in the bill? The House passed a bill that includes about $900 billion of savings out of the Medicaid program. Just for a level set, that's a little more than 10% of the total federal spending on Medicaid during the same window of time that the policies apply to. That's major. That's not like a little trim around the edges. That's a huge amount of money that would be cut out of the Medicaid program. The biggest buckets of where those savings are coming from are in changes to the way that Medicaid expansion happens in the states. So that is for non-elderly adults who are below 144% of the federal poverty level, who don't have other qualifications. So they are not disabled. In most cases, those are parents. In a lot of cases, those are also non people who do not have dependents, but they are adults for the most part in the expansion population. Another major change in the bill is to create, for the first time, a Medicaid work requirement. So people who would, um, in that same expansion population, would be required to meet a work reporting requirement in order to stay eligible for the Medicaid program. This is really tricky. I'm happy to talk a little bit more about what this looks like, and especially about how it impacts children, because the work reporting requirement itself does not apply to kids. No kids are required to work. Um, Despite sort of the gestalt happening around the country about maybe whether teenagers should get a job. But we're certainly not expecting children to get a job in order to qualify for Medicaid, but parents would definitely be impacted by this. The biggest sleeper issue here that I think is harder to understand is a change in the way that states are able to raise their share of the Medicaid program, of the Medicaid budget. So Medicaid is a state federal partnership, which means that the federal government sets a minimum floor of what the program has to look like, and states are able to innovate beyond that to either add more people who can qualify, to add different benefits, to add different types of providers. But there's a floor that they have to meet to participate. And in order to incentivize states to take up the Medicaid program in the first place, starting in 1965, the federal government offered to pay for the majority of the program. So every state gets, at least for every dollar that the state spends on Medicaid, at least 50 cents of that dollar is federal dollars. So 50 federal cents, that was a confusing dollar cents thing there. Apologies. We've got, for every dollar, it's 50 cents federal, 50 cents state. That goes up in the federal share to up to 76 cents federal, 24 cents state. So depending on the state's level of per capita income, we have either more or less federal dollars coming in for every cent that the state spends.
Phew.
Right
Okay.
now,
Very
uh,
helpful.
right now, a state can spend as much as they want. However many dollars the state is able to allocate to the Medicaid program, there's no cap on how much federal funding will come in to meet that. So when a state has a big issue, like if there is a natural disaster and there are a lot of people who um, are injured by a hurricane, a fire, and they have a greater Medicaid need, the state will spend more money and more federal dollars come in without a cap. Um, we are not currently talking about federal caps, but we are talking about changing, limiting the way that states are able to raise their own budget. So if there are changes in how states can raise funding, besides sort of general taxation, general income tax, or other sort of general revenues, states are going to have a really hard time being able to raise the number of dollars that they currently need to spend on their Medicaid program to keep it as robust as it is now.
Yeah, I just want to pick up on a couple of things that Stephanie said. First of all, while we're sort of getting into the nuances of the bill, well, not really nuances, but sort of the general things that are in the bill, I just want to take a couple of steps back because if you if you are like many of us and you're a neonatologist and you work in a large health system or you work for a children's hospital, um, you get your salary. Most of us are salaried employees, right? But I don't think people really understand exactly how important Medicaid is to children's health care. That's number one. And then number two is I think the discussion that Stephanie said, which is that the work requirement issue and what does that mean in terms of parents and parents insurance coverage, right? So the first thing I want to say, and the word that I guess people in the AAP use that I've learned a lot to sort of parrot is foundational, right? Which is that Medicaid is really foundational, not just for children's healthcare, but particularly for us as neonatologists, right? So we have about 50% nationally of all children in Medicaid and the companionship chip program. All right. If you look at births, which is really where our business comes from or our babies come from, right? It's about 41% of births. But if you look at high risk births, we're now 55% of high risk births are occurring in the Medicaid program. So I tell you, Daphne, what I tell my fellows and what I tell my colleagues, which is that whether you like it or not, directly or indirectly, we are all paid by Medicaid. It's just how many steps exist between sort of our work and the policy at the federal government. Um, the other thing that's really important is that when we look at how children are covered in this country, right? We look at Medicaid, we look at CHIP, the Children's Health Insurance Program, we look at employee sponsored insurance, which is probably how most of us have our insurance. We get our insurance through our employer. We choose our program, and then our children are covered as part of our family, along with our dependents, spouses, and other things like that, right? With the exception of maybe the pandemic, the number of children who get insurance that way tends to be relatively constant, right? Employee sponsored insurance tends to be relatively even. So that means when we're talking about uninsured children, the number of uninsured children is essentially a mirror reflection of Medicaid enrollment. When Medicaid enrollment goes up, child uninsurance goes down. And you can actually see these graphs. If you plot these graphs right next to each other, I do it in sort of a talk I give. You see as Medicaid enrollment begins to go up, as a mirror image, you see child uninsurance begin to go down. The other thing that's really important, and I say this because I know neonatologists focus on this a lot, is the equity piece of this, right? Um, we are paying more and more attention and beginning to understand more and more that treatment within the neonatal intensive care unit is not always the same. But I would argue that we are probably a little bit immune to the impacts of the disparities that occur in the outpatient world, right? In the outpatient world, there's a lot of disparities in access to care because Medicaid payments are low, and you have physicians who can only take a certain percentage of their total patients. So if I can see 100 patients, I have to cap the number of those patients that are Medicaid, 5%, 10%, or 20 or so percent, right? But all of us like to think that the care we give in the neonatal intensive care, we just take care of the patient in front of us, right? Most of us don't even know what insurance the babies have until it's time to maybe transfer them or send them to another level of care or discharge them. But if you look within the Medicaid program, about 65% of births in the Medicaid program are to Black or African American children. Compare that with about 20% or so um, that are self-described as Asian, right? The reason that's important is because when we look at our neonatal intensive care units and we say we get to give the same care to the best that we can to all of the babies, part of the reason that playing field is even as level as it is because of Medicaid. You don't have hospitals saying we're not taking Medicaid for premature babies, right? And I think that's really important for us because when we talk about Medicaid, we talk about sort of the policy nuances and the funding, but we don't talk about its tool in the inpatient setting to provide health equity.
That's very helpful, and I was not familiar with that, but that makes a lot of sense. I mean, that's how we can provide all the care for everybody, and I think you brought up some other interesting points about, especially neonatologists. We think we really don't. I say we think about it. We really don't think about all the time how payments are coming in. We come, we go to work, we do the best we can for babies and families. And so I think most of us don't think a lot about how we get paid in the NICU. And even beyond that, I mean, the services that Medicaid provides to our babies that we're putting out there in the world, I mean, are extraordinary. Therapy, transportation, all of those 5, 6, 10 follow-ups that we've scheduled for the babies, postpartum care for moms so that they're healthy enough to take care of their babies. So I think we're starting to recognize as a community that what we do in the NICU is very important, and how we set babies up after the NICU is equally important. All that work we've done to not set babies up for success in the outpatient world seems like totally bonkers. So I really appreciate how you have kind of set that up for us.
So 4 out of every 10, I just say babies but I forget there are children that exist too, right? 4 out of every 10 children with special healthcare needs, all right, are covered by Medicaid. And that's because those children on average use about $20,000 in outpatient services per year, as opposed to a child who doesn't have special healthcare needs, which uses only about $1,000 to $2,000 on average, right? Because you have some hospitalizations and ER visits in there as well. So we're not only using Medicaid as a tool to make sure that everyone gets care in the intensive care unit, but we're also using it to somewhat level the playing field to make sure that our kids continue to thrive once they're discharged. Now, about parent coverage, because this is one thing that we really need to then go back to with Stephanie to talk about as we sort of delve more into the bill. It's really easy for people, and I've seen politicians do this. And when you raise your hand as the sort of neonatologist in the room or first of all, you say pediatrician because people don't even know what neonatologist is.
That's right.
And you start complaining about the impact on children's coverage, the response you get is kind of what Stephanie's alluding to, which is they say, well, these are work requirements for adults. We're not touching children's coverage, which is financially almost impossible, but that's really what they're saying, right? But we know that there's a direct correlation between parent coverage and children's coverage. There's a great article by Venkatharami and a couple of other articles that came out really around the same time that said if the parents are covered, there's a 30% increased chance that the children are also covered. And that occurs through early childhood. So if you start undermining, by extension, you start undermining the ability for parents to have insurance, you're going to start cutting into the rates of insurance for children.
Yeah. Yeah, so it sounds like a lot is on the line here. And Stephanie, you gave us such a nice overview of the program, especially this kind of federal state situation. And I recognize that the way that that's set up makes kind of advocating for the program hard. Tell us a little bit about, why that makes the program more vulnerable.
One of the things that is particularly challenging about the setup is that there are federal policies that again set the floor, but then every state and the territories actually as well each get to decide their own policy lever, their own program design after that. So we do a lot of sort of whack-a-mole trying to figure out where are states doing a great job, where are states doing a mediocre job, where do states need to hear really loudly from pediatricians, from neonatologists, from others about decisions that they're making that are going to disproportionately hurt children and families. And that's it can be really tricky to track all of it because it's happening in a bunch of different ways at the same time. A couple of things that we are paying a lot of attention to here, which are not directly required by the House bill that Congress is not currently considering directly, are the choices that states would be making if this goes through. So, because the cost shift to states here is so large, the cost savings that states would have to figure out how to make are so dramatic. There are a bunch of choices that we think are very likely that states would make that would have a major impact on kids and families. One of the big ones is most almost every state now has taken up 12-month postpartum coverage in Medicaid, and that is awesome. I think you guys understand this really well. It is so important that those new moms retain coverage for that first year of life, and that is an optional benefit. It's an optional coverage package, and if states are looking at ways that they can quickly trim their costs in the program, if they need to find ways to really quickly shrink their Medicaid program, that's one of the first policies that we expect to be rescinded. So we would expect that a lot of states would really quickly undo their 12-month postpartum coverage policy, which would mean that new moms would have 60 days of coverage instead of 12 months of coverage. That's really a big loss for those moms and those new babies. A second one is there are a good handful of states, about 14 states, that have a trigger law. They have expanded the Medicaid program already, so they have coverage for that population I was talking about. That's mostly parents, low income parents. But there's a trigger law on the books right now that says their state legislature has said we're going to do this, but if the federal government changes their agreement and says that they're going to pay us less for the Medicaid expansion population, that cost sharing, the number of cents of federal cents and the number of state cents, if that shifts and the state has to pick up more of the dollars, then we're automatically going to take away the Medicaid expansion. And that would have a major impact on how many adults are able to get coverage. As Shetal has said, that has a really big direct implication on how many kids are covered. Even children who are eligible lose coverage when we see adult coverage go down in this kind of a policy. Um, and we know that there are also a lot of indirect impacts of parents losing coverage, where we have parents who are making other decisions about whether they meet their own medical needs. If they themselves are uninsured and they don't take care of their own health, we know that there are a lot of mental health issues that indirectly impact kids, as well as the sort of financial stability of the family that has impacts on housing stability, food security, other types of spending choices that families are making. So those two policies in particular are not impacting kids coverage, but they are indirectly impacting the sort of family setting. The other major policies that I think we're really concerned about that do more directly impact kids are how states are going to shrink some of the optional benefits, particularly and especially relevant for NICU grads. The home and community-based services are not optional for kids, but they are optional for adults. So when a state is setting up all of the services that they are offering in the home and community-based service space, the specific providers that they are contracting with, the payment rates that they are offering, the types of services that they've decided to include in their adult population, all of those actually have a big spillover impact on what children are able to access as well, because it changes the infrastructure of what the healthcare system looks like for the whole state. we think that there are already kids who are on waiting lists for services to be able to keep them safely at home. And we think that those are likely to get worse if states see a major budget cut here, which makes me feel really nervous about how this
Yeah.
might be impacting a lot of your former patients.
Daphne, there's also something that, we're spending a lot of time talking about the nuances about how the federal government's going to sort of shift the cost to the states, right? And there are lots of sort of even things like provider taxes, which I kind of want to touch on just because I kind of think it's interesting. But I was in states know this is coming, right? They're not blind to what's going on in Washington. So they're already preparing not just their regular state budgets, but what, at least in New York, people are quietly referring to as the doomsday budget, which is what do they do if the Medicaid funding is gone? Because remember, the amount of money that the federal government provides to states for Medicaid, right, is a major part of the entire state's budget, right? Anywhere from 30 to, in some cases, 60% of the entire state budget is the Medicaid program, right? So they're already looking very scientifically at where cuts need to come from, right? So if you're a state government now, you have a few choices if you're not getting as much money from the federal government, right? You can raise revenue, which people don't like to do because state taxes, right? Election years and things like that. But you've got to impact payments, right? How much you pay, because that'll reduce the amount you're spending as a state. Who gets covered? If you reduce the number of kids who are covered, you're obviously going to reduce the number of people the amount you're paying, or you reduce the benefits, right? You can curtail eligibility too to also reduce the number of people who are covered. And I will tell you from having been in a couple of state capitals, they're looking directly at the NICU babies as a way to not fully close the budget gap, but as the first people on the chopping block. And while you and I sort of,
Because it's such a big part of the
right, well,
population budget, yeah.
it's interesting because I just had my hand in my head and I was just like, are you kidding me? On the backs of babies?
Mm.
But then they kind of explained it to me in the sort of cold calculus of a state,
Yeah, if you're a business person, right.
right, as a state controller, right? Because they don't look at the babies as like the kids that we like. They're like, oh, this one's cute, right? There's a small population, right, of ultra premature babies, the ELBW, even expand that to the VLBW population, right? 1.5% or so of babies that cost 60 to 80% of the total cost. If you curtail those payments, right? Number one, you impact a very small number of people relative to the entire state population. Number two, you save a lot of money relative to the entire state population. But number three, no hospital is going to say, well, you cut payments so much, we have to abandon the NICU. Because if you abandon the NICU, if a hospital really did that, OB would also go. And the money that OB comes in also helps fund the sort of medical center, right? So if you're a state controller or someone who's like charged and tasked with doing this, this is a great opportunity for you to potentially save money. Um, and we can talk about all of the relative added value that we provide in neonatology, saving the lives of patients that didn't even exist 20 years ago, and having them all go on to live healthy lives and all of the economics and, economic multipliers. But they don't have the time to be that long-sighted right now, right? They're losing 60% to 30 to 60% of their state budget, and they need to find out where that money is coming from. And that's part of the reason I really wanted to bring all of us together, because this really is not just a call to action for children, but is particularly putting a spotlight on the care that we provide.
Yeah, I think that really helps put it into perspective, and I think it's the perfect segue then to helping people understand. I think it's so good that we spent time talking about the federal versus state, because I think a lot of things going on at the federal level, individual neos are like, how could I possibly influence that? But it sounds like that potentially we have a lot of influence at the state level. So I'd really love us to spend the bulk of the rest of our time on what can we do about it, and how can we engage as individual clinicians, and what is the time frame in which to do it.
The time frame is now. Now is the perfect time to be reaching out to your policymakers, um, definitely to your senators, regardless of party. All of the senators need to be hearing from their constituents right now about how critical Medicaid is to your communities. That means that there are a handful of uh, Republican senators who themselves have expressed some concerns about the Medicaid cuts in particular, and we need to make sure that they feel supported in in continuing to say those concerns out loud publicly. There are several Republican senators who have not expressed any concerns about the Medicaid cuts, and I think it is important for them to hear that their constituents do have some concerns about these. And for the Democratic senators who are going to vote no on this bill no matter what. It's helpful for them to have stories about how important Medicaid is within their community to be able to emphasize its central role in supporting kids' health as this debate continues. Don't stop talking to your House members. If you are willing to reach out to your whole congressional delegation, both of your senators and whoever represents your district in the House of Representatives. Again, after the Senate finishes their work, this will be going back to the House, and so it's also really important that the House of Representatives hears from you as well. All of that said, that's great. You can reach out to them in a number of ways. You could call the Capitol switchboard. You could go, if you are an AAP member, you could go on to the AAP's Federal Advocacy Action Center, and we can help direct an email that'll help sort of like automatically send an email directly to the office for your address, and you can tailor those to talk about stories that you have about your patient population, about your hospital, your experience as a clinician. It also, as Shetal has said, after the federal government is done with their part of this work, it goes back to the states. And that actually means both that you can change the way that states consider their options in front of them, but also it means that those state policymakers, the state legislators, governors, state budget officers, state Medicaid directors, they are also right now reaching out to their members of Congress to talk about what this bill would actually do to their state. And that's having a really big behind the scenes impact in how each of the senators are thinking about their own votes. We know that there are multiple senators who are thinking not only about, what is the total impact of this bill on the federal deficit, or what is the total impact of this bill on the number of people with or without health insurance coverage, but also what does this mean for the hospitals in my state? What does this mean for the budget in my state? What does this mean for working parents in my state? And those numbers that are coming out of the state analysis are also really impactful. So reaching out to your own state policymakers is also really important. Right now is the time.
So I love that. So we can call, we can send emails, we can show up at their doorstep, and then Shuttle, my question for you in kind of in mobilizing our community, right? It sounds you've talked a lot about how the stories and our voices have a real influence. I think a lot of people say like, okay, I'll send a letter, I'll send an email, it'll just sit in their inbox. Like, do they even read it? So I'd love for you to talk a little bit about how you've seen, your own engagement make change.
Yeah, I think that the stories are important and the lines of argument are important because you, the senators and the other elected officials obviously they don't live our lives, right? So um, it's really important for us to keep on reminding people about how this is going to impact babies, right? Because a lot of this are frankly numbers in an Excel spreadsheet. And what the stories do is they humanize those numbers. And what the lines of argument do is they allow the senators and the House members who are not going to support this bill no matter what, right? It gives them a discussion point for people who are on the fence. So I'll give you sort of a perfect example. We mobilized a section on neonatal perinatal medicine letter writing campaign um, in the week before the House was considering this bill. We got about 75 letters out to about 65 different members of Congress. And it was great because each one of them were actually somewhat personalized. And they had stories of patients that people had taken care of or stories of what happened in the state. A lot of people talked about particular babies that they took care of during their training, right? Even if it wasn't in that state. But what was really important about that was that you also had a lot of people talking about the impact that this would have on the children's hospitals that they work in. And that's really, really important because senators, especially in certain states that only have one children's hospital, right? We have 18 in New York, right? Um, they're really proud of those children's hospitals, right? They love, you've seen the pictures. They're cutting that ribbon, when the new lobby is being made, right? They're, getting frozen yogurt when the new frozen yogurt machine is dedicated or whatever it is, right? Um, but that's really important for them for a couple of reasons. One, so obviously, if so many kids are covered by Medicaid and children are getting their care in children's hospitals, the children's hospital budget, right, is really based on Medicaid, right? In terms of the physician, the physician and the hospital payments, right? But if you talk to the Children's Hospital Association, the amount of money that Medicaid pays, right? Because Medicaid always pays less than Medicare, right? That was the whole parity argument, is only about 80% of cost, which means your entire children's hospital is basically running on the amount of extra money that it gets from private insurance, right? Which means our children's hospitals budgets are always kind of iffy, right? Compared to larger medical enterprises. So talking to them about how this is going to undermine children's hospitals for everyone is really important because people perceive of Medicaid as a social safety net. But if that children's hospital goes, it goes for everyone, right?
Everybody.
Even the people who have employee sponsored insurance and all of the special things that our children's hospital has, right? Pediatric dialysis units, pediatric burn units, level 4 NICUs, right? All of those things would go with it. And that's really important for people to understand because there's this belief that all of this is impacting sort of a population that's already sort of socially vulnerable, but doesn't have any spillover effects to all of us. And I found that line of argument as actually really, really critical because, like I said, if you're in one state that has only one children's hospital, right, the fact that that children's hospital could go, that shared resource is gone for the entire state is a really big deal because the senators don't want that, on their hands. And they certainly don't want to be blamed. They certainly don't want to be blamed for it. So in so much as we speak for the babies and in so much as we speak for our neonatal units, we really are speaking for the financial viability of the children's hospital indirectly, right?
It's not even just children's hospitals. Medicaid has a disproportionate role in rural health as well. And so those rural hospitals, the little community hospitals out that are on their own in rural areas are very vulnerable, and a lot of them are threatening to close entirely. That's going to create a lot more challenges. It exacerbates the maternity care deserts. It exacerbates lots of other issues where um, I would imagine that you guys would end up seeing more babies who require NICU care because of those local hospitals closing in these rural areas where it's just going to sort of undermine a bunch of the other pieces of that wider net. We'll just have bigger gaps that hurt hospital care overall for kids.
And I thank you guys for really summarizing that. I worry there's still people that are like, I don't want to, I can't do it on my own. Are there ways for people to get engaged with the AAP, with the section, to help make this a reality? Is there benefit to going in as a group from an individual hospital, working with our hospital C-suites? How are ways that we can make a bigger impact?
Sure. I think, first of all, congratulations to everyone who's just listening to this podcast because you've done your first step, right? Which is that you've gotten some background information about why this is important, right? Now that you've gotten that information and hopefully you're sort of activated and you want to do something. Now the question is how do you in the limited time you have, right? How do you make that action the most effective, right? So you have the Federal Advocacy Center at the AAP, which is really helpful because it allows you to customize sort of pre-templated messages and send them to your House members and to your senators.
That's
Okay.
probably the easiest way for people to get
That
involved, right?
takes I have actually
Yeah,
timed it. If you
perfect.
already know your AAP ID number, some of us, that's
You have
hard.
to look it up. Okay, fine.
No, casually drop it into conversation.
That's it.
Then it literally takes 3.5 minutes.
So
I've timed
everybody could do that, right?
that if you yeah, if you the hardest part is looking up your AAP ID
Right.
number. Um, but it takes about 3.5 minutes, and if you wanna customize the letter, of course, it takes a little bit longer. But that's just one thing you can do, right? The other thing you can do is you can connect with your AAP chapter. They're doing a lot of work on this. Um, and they're focused a lot on the sort of spillover effects into outpatient practice, right? Um, if you want to get more engaged and you want to speak for the children's hospital, right? So now you're changing your role from shuttle shot neonatologist on the street to uh, a representative of the children's hospital. You should talk to your government affairs folks and tell them that you want to have a more vocal role. They would. I've never seen a government affairs office that doesn't want more physician input, more physician activation. They love it when physicians speak. We speak with a certain amount of authority. We speak with the value of all of our experience. And to some extent, they're viewed as much as they're talking about children's hospitals, they're viewed as lobbyists for the children's hospital, whereas we're viewed as advocates for our patients. So I think that's really important. And then, of course, the other thing to do is develop a relationship with your Senate offices and your congressional offices. I'm not saying you have to be, I mean, I tend to go to my congressional office about 4 times a year. I'm not saying you have to go there 4 times a year, but you should know who the healthcare staff person is. You should develop sort of an email relationship by sending them stuff and saying, hey, I know this is coming. I want you to know this is what I think, and this is why it's really important. And if you want to speak to other people about that, I can facilitate that for you. I can arrange that for you. The same thing is true with your Senate. You should know who the Senate healthcare staff people are and try to develop at least a relationship with them. I tell people all the time, people ask, well, how do you do it? How do you do it? I said, it's no different than if you're at a referral center and you have to maintain the relationships with all the hospitals that send you babies, right? You call them up, you give them information, right? You follow up with them. Just sort of general collegial sort of interaction that we do all the time for babies, it's the same exact thing. And eventually what happens is they just start picking up the phone and calling you because they know, okay, well, wow, this is it's a children's health thing. Oh, well, what does Daphne think? Or, oh, it's something that affects, the French. Let's call Ben, right? Like it becomes something that you become the local resource.
Mhm.
So I
When
think
when they
that's
need
really,
somebody, they'll reach out. That makes a lot of sense.
yeah. And
Yeah.
that's the person you want to be. You want to be the go-to person for child health because that way you can always make sure they're on a path that prioritizes children.
Okay. And what is our deadline then to reach out to our senators? What should be our deadlines?
There's no deadline. Today is a great day.
Perfect. I like that. Okay. Okay. Well, I really appreciate one the work that you both are doing, not just now, but all the time, to protect our workforce in addition to the babies and families we care for. And two, for giving us this lesson in how bills are made and what's going on in our government. And three, for really educating on how we can get engaged. I want you guys to have the last word, though. Any closing thoughts?
Just to reiterate, you are the right person. Any of you who
Hmm.
are still listening, you've made it through. Thank you for joining us on this journey. You are absolutely the right person to make this argument, to tell the policymakers about how critical these programs are. As Shetal said, you have a ton of credibility. And even if you feel like you're writing into a black box, someone is reading that email. Someone is reading your letter. I promise it. I've seen the tallies that they put together of what issues are coming up from which constituencies on which days. And so it is really important that you add your voice into that mix.
Yeah, and I would only say that for some reason there's this belief that we have to be the expert, right? We have to be the person who knows everything about these programs. And that's not true. We just need to know the life that we lead and to what extent these changes in Medicaid might impact the care that we provide or how we provide it. I always tell people we're the experts in our own lives, right? So we definitely don't need to be the expert on all the policy nuances in Medicaid or, we don't need to, if Kaiser Family Foundation releases something, we don't all need to just jump and read it. Um, you just need to speak on behalf of your patients. And I say that all the time. I say, I'm here because my babies are on a ventilator and they can't speak for themselves. Now we know that they're not all on ventilators, but that's okay. But some of them are on CPAP, right?
Yeah.
Um, but I think that that already establishes who you are and what sort of your motivation for taking the time to do this is. Um, and it always said, one congressman once pulled me aside and said, he was just talking. He's like, you always get this whenever you meet with Congress. Oh, I love pediatricians. They're so great. My pediatrician was so nice, right? But then he pulled me aside once. He goes, I love talking to you baby doctors because again, the ability to confuse neonatology with
Sure.
neurology in and of itself cracks me up all the time,
All
but
the
it
time.
happens a lot. Um, and he goes, because no one speaks with more moral authority,
Hmm.
right? We walk in with more moral authority than anyone else in any advocacy conversation because we've dedicated our lives and 10 years of training to babies, right? And by definition, people assume that if you do that, you must be like a semi-decent person, right?
I love
So
So what I hear you saying is we don't have to be an expert in policy or in advocacy, but we
Mhm.
are already experts in babies, and that is valuable enough.
Absolutely.
I love that. I love that. Well, on our show notes page, we will have some links to help people get engaged quickly. Maybe a format letter. We'll come up with some good things to have available. Stephanie Shetal, thank you so much for being here. Thank you for your time.
Well, thank you for having us. You have to tell Ben we missed him.
Will. I will. And then you had them on our first attempt for recording, but I want to get one of those I'm just a Bill t-shirts.
Oh, yeah, no problem. We can definitely hook you up.
All right. Thanks so much.
It's only fair because you guys hooked me up with an incubator t-shirt. That was exciting.
All right. Thanks everybody.